Welcome to DMV Spotlight on ESPN 630, the sports capital, where we shine a light on local stories from D.C., Maryland, and Virginia to inform, enlighten, and inspire you from local organizations doing the same. I'm Barbara Britt, and my guest this morning on DMV Spotlight on ESPN 630, the sports capital, is Dr. Tisha Wiley. She heads up the J-Coin initiative at the National Institute on Drug Abuse. And you're wondering, what's J-Coin? Well, we'll get to that in just a second. But essentially, we're going to be talking about opioid abuse and what is happening at the National Institutes of Health, specifically the National Institute on Drug Abuse, in trying to address it in the criminal justice setting, which is just fascinating to me. So I want to thank you so much for joining me on DMV Spotlight.
Thank you for having me. Excited to be here.
Thank you. So let's start at the beginning. Obviously, people around the country, everybody is now familiar, sadly, with opioids. Mm-hmm. Sort of give us a background. How did we get here? How did we get to this point?
So we have seen rising deaths related to opioid use over the last several years. And there have been a number of reasons for that, including there's certainly contribution of prescription opioids, but also illicit opioids like heroin. There's been an increase of what's called fentanyl in the supply of illicit opioids, and that is leading to a lot of people, unfortunately, dying related to opioid use.
Now, we had heard that fentanyl is honestly like elephant tranquilizer, like not even joking.
So carfentanil is actually sometimes used as an elephant tranquilizer, but fentanyl is just much more potent and powerful than heroin. Different opioids have different potencies, and so fentanyl is particularly potent, which means that very, very small doses can lead people to die, unfortunately.
And we know, we've seen this, in the news where you will have actually local law enforcement will put out warnings to their local community that they know use or abuse drugs and say, hey, we have a really bad batch on the street and you all need to be super careful. I'm picturing in my mind, it was in Connecticut, it was a park, and there had been a bad batch, and literally 100 people, they were carrying them out as fast as they could. It's just terrifying that this kind of thing is happening. But so happy to hear that you all not sitting back and just letting it happen. So I know that specifically at the National Institute on Drug Abuse, there's a broad approach that you're taking. So we're going to talk a little bit more today about what's going to be happening with reforms in the criminal justice system when it comes to treating opioid abuse, but in other areas as well. Can you give us a general overview?
Sure. So in response to all of the fatalities that we've been seeing related to opioids, Congress appropriated $500 million in 2018 to NIH for what's called the HEAL initiative, which is helping end addiction long term. So there are several parts of that. There's a focus on pain. There's also a focus on addiction. And J-Coin is one of the pieces of that. So J-Coin stands for the Justice Community Opioid Innovation Network. So we are, over the course of 5 years, we will have $155 million that we're going to dedicate to this initiative. And the reason why, I know you mentioned there's lots of strange government acronyms. The reason why J-Coin starts with justice and community is that our perspective is that really what's important in addressing this issue from the perspective of the justice system are partnerships between justice agencies, so jails, drug courts, things of that nature, and community-based providers, because most of the folks who come in contact with the justice system, most of them will actually end up returning to the community. So it's really important not just what happens to them while they're in a jail or in contact with the justice system, but what happens when they return to the community and how we address their needs while they're in the community. So that's why we have that focus. NIDA has had a long history. Drug abuse and the justice system, our substance use in the justice system have a long history of being intertwined, because many of the things that people use or are addicted to are by definition illegal. And so that will bring people into contact with the justice system. So we've had a long history of identifying that as a important priority area. And so when this opportunity came through HEAL to address opioid issues, that's why we have this focus now on the justice system.
That is fantastic. And I know you're a doctor, so I want to go back and just ask you, I know that opioids in general change patterns in your brain. And so that when we think about people with addictions, however we might feel about that, it truly does change how you think. Help us understand that.
So I'm not a neuroscientist, nor am I a medical doctor. I'm trained as a psychologist, but we do know that opioids, when people become addicted to opioids, it changes the way that their brain functions and responds to naturally occurring opioids. So one of the reasons that why some of the medications we use work is because they help address those things that happen in the brain that make people compulsive about how they seek out opioids. And so a lot of the medications work by, it's almost like we use a lock and key analogy sometimes. So they fit within the neuroreceptors of the brain and help get people in a place where they can actually function in their day-to-day life.
You're talking about when you're trying to get them off of opioids?
Yeah. So yes. So whenever I'll have to say, I'm not a neuroscientist, so this is where
totally
I stumble the most in describing
fine.
it. But so yes, when people are addicted to opioids, their brain, there are certain parts of the brain that need the stimulation of the opioids.
It craves it. It literally
opioids.
gives the message, if you do not have this drug, you are going to die.
Yes.
That's how people feel.
They feel so when we define what an opioid use disorder is, it is defined by compulsively seeking your drug of choice despite consequences like losing your job or getting arrested, those kinds of things. So a lot of the medications that we have that are really effective at treating opioid addiction address those issues in the brain so that people can focus on what they need to do, all the other parts of their life that whenever they're in that state of addiction that they may neglect.
I think that's fascinating that there's even drugs that can help people get off opioids.
So there are 3 FDA-approved medications. One is called naltrexone, another is called buprenorphine, and then there's methadone. So those are the 3 FDA-approved drugs that have many, many studies that support those as being effective treatments for opioid addiction.
And I think methadone's been around for a long time, hasn't it?
Methadone's been around for 50 or 60 years.
Wow.
And so and buprenorphine has been FDA approved, I believe, since the early 2000s. So we've had a lot of options to treat people for a very long time. And really the philosophy of this initiative of JCOIN is making sure that when people are involved in the justice system, that they also have access to those medications, and that whenever they return to the community, that they have access to those medications as well as to other treatments that have been shown to be effective at addressing their opioid addiction. And we know that's actually something that doesn't happen a lot. So
I was going to ask you, so are you saying that this would be available for inmates, somebody who is incarcerated, they would be able to now essentially get treatment for their addiction while they're in jail?
Yeah, so several of the studies that we're doing are going to look at that, or look at it at least at the transition. So one study, for example, is in Massachusetts, and in Massachusetts they passed a law last year that basically said that while people are incarcerated, they need to have access to all 3 FDA-approved medications. That was based on a very successful study in Rhode Island where they did that, and showed that there was a very significant drop in mortality, not just for people who were justice involved, but at the entire state level. That drove a drop in mortality whenever you were treating the folks that were while they were incarcerated. So in Massachusetts, they are going to put in 7 jails in Massachusetts. They are going to experiment with a program where they make all 3 medications available. And we are able to put researchers and partner with the sheriffs and other folks in Massachusetts that are doing this so we can study how that works and maybe figure out how other places that might want to replicate that approach can do it in the future, because there's increasing interest in doing that.
That is fascinating that they can do that. has there been any pushback?
So, so one of the things in Massachusetts is, it's a pilot program to see how is this going to work. So rather than immediately going to all of the jails in Massachusetts, they're starting with 7 jails. And so this is an opportunity for us to learn from how that program rolls out, what works. Certainly there are logistical challenges. Methadone has lots of regulatory barriers, and so jails have to figure out how are they going to navigate those barriers. And so what we're really hoping to accomplish with this network is not only do we learn whether that works, but we learn how to help other folks model after that and put those successful programs in place throughout the country. So we have a lot of things that are geared toward helping translate that back.
And Dr. Wiley, that's why it's so exciting that you all are beginning this program, because we really do know what doesn't work, and what doesn't work is what's happening now. That's not working for the most part.
Right.
More people are becoming addicted. The penalties are not enough. More people are dying, and younger people are using drugs as well. So you mentioned Massachusetts. So circling back to initially, you said that there had been a health initiative, the HEAL initiative from Congress, and you had gotten some money through the National Institutes of Health, and specifically through the National Institute on Drug Abuse, to award some of these grants to come up with this JCOIN, this Justice Community Opioid Innovation Network, JCOIN. Much easier to say now. I know why you all do that. So you mentioned Massachusetts. What are some of these other programs that you all are trying to do some of this testing in?
So another place that is like Massachusetts, and that we're looking at what's happening as a state model rolls out. There's something called opioid courts, which are an adaptation of drug court models in New York. And in New York, they plan to roll out that opioid treatment court model across the state. And so there we funded a researcher that's going to partner with the state and help understand what that rollout looks like and see what works and what doesn't, and try to learn from that experience.
So for those of us who don't necessarily know what drug court is or opioid court, back us up a little bit and help us. What does that mean? So
drug courts, sometimes whenever people are arrested and their only crime is perhaps possession of a controlled substance or a minor property offense, sometimes they're given an opportunity, rather than to go in jail, they participate in a drug court, which often has requirements about how they engage with treatment. And once they meet those requirements of getting treatment, they're under community supervision, so probation typically, and their involvement with the court is also an opportunity for them to be involved with treatment. So an opioid court is an adaptation of that that's very focused on the issues that are specific to an opioid addiction.
So instead of we're talking about non-violent offenders, let's make that clear.
Yes.
We're talking about petty crime, robbery, people sustaining their habit, people who are addicted to drugs, and in this case specifically opioids. I mean, I know up in Frederick they've had great success with their drug court, and they make offenders essentially go to recovery. It's their rock bottom. You're like, okay, you're either going to go to jail or you're going to go to recovery.
Yeah. So each drug court is able to define its own specifics about who's eligible to be involved, but in general, you're talking about folks that haven't committed an offense that is really a threat to public safety, and the way you're right, it's not typically a violent offense, and so yes, it's an opportunity for them to engage in treatment, and many evaluations have shown that to be a very effective approach. However, historically, a lot of drug courts did not allow people to be on medications, the 3 FDA approved medications, if they had an opioid addiction. So an opioid treatment court really starts with more the philosophy that they should have access to those medications while they're being treated.
And you mentioned that they do this up in New York. Is this somewhere where they're supervised, like in a halfway house type of situation, or does it just depend on where they are?
I think it really depends. And so often drug courts are very, they each can have their own set of parameters. So I don't know that specific if it would all be folks that are in a halfway house, but it's people that are involved in a drug court. That's the nature of their offense, and it's specifically about integrating access to medications for their opioid use disorder as part of that model of the drug court.
So again, part of what one of your grants is going to go and study this, and if this is in fact going to be successful, and then you would perhaps spread it across the country?
Yeah, so if it's successful, then hopefully we will be able to take those lessons learned. A big part of JCoin is not just these, we have 10 individual research projects, but we also have 2 different supportive centers that will help us do a lot of things. And one is our Coordination and Translation Center. And so what they will do for us is as this study in New York is wildly successful, they will help those investigators take and distill those findings into resources that are going to be really useful for other folks around the country that might want to stand up their own opioid treatment courts. So they will bring in key state judges, prosecutors, other folks around the country to help identify what would those folks need if they wanted to stand up their program, and then help us figure out how to take what we get from this research study and turn it into a format that's really useful for people who are out there in the field and doing this work on a day-to-day basis. So we think that that's really one of the exciting aspects of what we're doing, that we're really trying to bridge that what people sometimes talk about as a gap between research and practice. There's an often cited study that it takes 17 years for a research finding to make its way into everyday practice. That's often been true in medicine, and so really what our goal is to reduce that timeline so that we're understanding what's important to the folks that are out there in the field working with people every day, and we're taking what we find in these studies and helping make it into useful formats that will be valuable to practitioners.
That is fantastic, because as any 17-year-old can tell you, that's a lifetime. But that is true, and I'm so thankful to know that that's where some of that money's going. Okay, so that's a couple of these programs. Give us an idea of what some of the other ones are as well.
So another, we have 2 sets. There are 2 new medications that are long-acting buprenorphine formulations. So what that means, typically whenever you take these drugs, whenever you take these medications, you have to take them on a daily basis. Sometimes people find that really hard, so the long-acting formulations can be really helpful. So recently the FDA approved one version of a long-acting buprenorphine that lasts a month, and that's called Sublocade. There's another product that's also been FDA approved but not yet ready for marketing called Comm 2038 or Brixadi. We have 2 studies that will look at what happens whenever you give people access to those 2 medications, and they will be compared to a long-acting version of another medication, naltrexone, which is often commonly known as Vivitrol. So we will have 2 different head-to-head comparisons. I think cumulatively across these we'll have 1,000 patients enrolled in 6 different states, looking at comparing what happens when you take buprenorphine versus long-acting buprenorphine versus long-acting naltrexone whenever your justice involved, and see what works better.
I'm speaking with Dr. Tisha Wiley, who heads up the JCoin initiative at the National Institute of Drug Abuse, and we are talking about JCoin, which essentially is the Justice Community Opioid Innovation Network. And it's a series of grants that have been paid for essentially by American taxpayers, but are going to really try to address the opioid crisis within the Justice Department and that combination. So when you get these patients together, these 1,000 patients, are these people who are volunteering? How do you find them?
So the researchers work with they will all be recruited, as I understand it, from jails as they're about to return to the community from jails. So this is about giving them access to medication before they return to the community and ensuring that they have continuity in the availability of treatment there. And so in each of these places, they've found a jail that's willing to partner with them, with a community-based treatment provider that would be providing that treatment. And so the researchers in those 2 particular studies, they will recruit participants. The participants will agree. They'll receive the medication for, I believe, 6 months to a year. And they will then follow them for another year to see what happens.
And then you all will get some of that information back.
Yeah, so we have really amazing researchers. At the New York School of Medicine and Friends Research Institute, those are the 2 teams that are leading those 2 projects. So yes, they work very hard. to follow those patients and see what happens to them and collect outcomes that are of interest. And one of the things they'll say we're doing too, in terms of the way we're engaging with key stakeholders, is we're trying to make sure before those studies go in the field, we're trying to find out from a sheriff's perspective, from community treatment perspective, what are the most important outcomes? How should we be measuring recidivism, the effect of recidivism, or whether people return to use? And so we're trying to make sure that we listen to what are the most important outcomes from those stakeholders' perspectives, and then we'll make sure that those get built into these in both studies, so that both studies will have similar measures, which will make it easier for us to compare the outcome from the two studies, even though they're being conducted by two different research groups.
And that's a really comprehensive approach, isn't it? It's sort of been piecemeal over the years, not throwing any stones at anybody, just everybody has their own little area that they do, but obviously it all overlaps at some point.
Yeah, I think that's why we're calling this a network. It's meant to, we're trying to figure out ways that we can make this effort more than the sum of its parts, so that we have common measures that mean that you can have each study, even if they're very different or conducted in different places, that we can compare the results of those studies, or that they're going to be of interest to, like, we wouldn't want to get to the end of the study and have someone say, well, I don't care about that outcome. This is the outcome that's really important to me. We're trying to be very proactive about putting that in at the beginning of the study, so we know what's really important.
So you mentioned that you had some institutions and locations, but you have a whole long list here. Brown University, University of Chicago, University of Kentucky. What are some of these other ones doing?
So the others, I would say the overarching theme for the other group, which is really 6 of our studies, are focusing on what I would call a case management or peer navigation kind of model. So that's about so when someone returns to the community from a jail setting, or when they're on probation or parole, they have a lot of things they're supposed to do, not just get treatment for their addiction, but also get a job and find housing and all of those kinds of things. So each of these, there's sort of 6 different approaches that we have, and each are taking a slightly different approach to it, but really they're all about, do we make someone who's already gone through this and have them help you navigate that? Do we have a case manager that helps you address all of your needs? We have one that's based, for example, at Yale. They're using a model called Transitions Clinic. And so that's situated in primary care clinics. So it addresses not just your addiction, but any other physical health issues that you might have. And they have folks that help you navigate all of that stuff but also it hinges around a primary care clinic where you can get care not just for your addiction, but for any other ailment that you might have. And so that's a really innovative model that exists around the country, and here we'll be looking at what happens whenever you expand that to addressing opioid addiction.
That's fascinating. It's a very holistic approach, and that very, very innovative, because you do think about the average person who gets released from jail, just very generally speaking, they tend to go back to where they were, right? Because where else are they going to go? They're going to go back to the same community, the same people that they were with, the same people maybe who were not a great influence on them to begin with, back to the lifestyle that they knew, because that's what they know.
So all of these models, each, like I said, there's a little bit of variation in what they're doing, but we have one that's focused on what are called recovery management checklists, which are a way of following up and seeing how you're doing after you've received treatment. Another one that uses a center model in Chicago, one that's focused specifically on telehealth approaches for women specifically.
Tell me about that.
So that's in Kentucky, and in Kentucky, women are often underrepresented in these studies. And so in Kentucky, we will have a group that will go in and identify women who have an opioid addiction. Same kind of thing, help them with some case management and recovery management kinds of things, but also look at what can you do with telehealth to support their recovery from their addiction. And so we're really excited about that as well. So
telehealth, just give us a working definition, because I know that's still relatively new in some senses.
Yeah, so telehealth is it's really important in rural areas. So in rural areas, your therapist may be an
Far
hour
away.
more from you. And so telehealth uses technology to facilitate people receiving access to their therapist. There's versions of telehealth where they can even observe whether you're taking your medication or not. And so it just facilitates that you can have that interaction with your care provider, regardless of whether you're in the same room or not. You can just use your phone or your computer and have that.
Is there a visual component as well sometimes?
Sometimes, and I'm not sure specifically in this project of the telehealth. I'm not sure the details of their particular telehealth approach, but they're using that approach and are probably going to be designing it as they go to identify what are likely to be the most effective elements. And so again, they'll design that. That's the kind of thing that whenever we get to the end of the study, if it proves to be effective, then other places can pick up that same intervention and use it for their community, even where they have folks that are geographically not near the nearest treatment provider. So it's a really exciting approach.
That is very cool. And I have to ask, when obviously when you're talking about women and drug abuse, specifically opioid addiction, obviously very quickly get to the children. You get to that aspect as well, and then that goes into foster care, and it goes into a whole difference. I keep thinking of a rock in the middle of a pond and all of these things circling out from that. Is that any component of your studies at this point?
Right now, we don't have anything that's specifically focused on child welfare. However, I think that certainly will be one of the things that the Kentucky study looks at. There is another initiative called the Healthy Brain and Cognitive Development Study, HBCD, which is going to be looking at, for those children that are exposed to opioids while their mother is pregnant, what happens to them long-term developmentally. That'll build on some infrastructure we have where we followed adolescents over the long term to see how their brains change in response. So we have that, and then the National Institute on Child Health and Human Development, NICHD, is leading another study that falls under the HEAL umbrella called NOWS, which is the Neonatal Opioid Withdrawal Study. I believe I got the acronym there right. So we're not specifically focused on that, but all of those issues are very interconnected, and those are two other initiatives within the HEAL umbrella that are addressing those issues.
So let me help my own brain take all of this in. This is a ton of information, and it's very high up here, and I love it, and I'm so thankful that you can explain it to us. But you have these different grants. You're going to collect all this data. You have people helping you do that and distill the information. Mm-hmm. Is this then going to go in? Is the National Institute on Drug Abuse going to go in and meet with some of these other institutes and gather their data as well? And will there be a comprehensive approach, or is each one going to do their own?
So each of these initiatives has a piece that they are focused on, but we are working internally at NIH to figure out how we're going to make all the pieces talk to each other. So that is certainly an issue that we're thinking about. How do we make the big picture clearer? And so we're all having different conversations internally to figure out some of that, because this by itself is very complex, and then it's part of an even bigger, more complex picture.
So ideally at the end of these particular studies that you are responsible for, or you have a piece of with the grants, will there be, a sheriff in Nevada who can go on the website and say, wow, these are the best practices that have been recommended at the National Institutes of Health? Is that something that you all are working towards?
Yes, that is definitely something that we would love to see, that sheriff can go to our website whenever, which doesn't exist yet, but will exist eventually when we get to the end of the study. Yes, my hope is that sheriff that says, I'd really like to figure out how to do this, that they will have a set of resources they can go and figure out, this is what worked, this is how I do it.
That's fantastic. I want to thank my guest this morning. I've been speaking with Dr. Tisha Wiley, who I think has made us all a little bit smarter today just by listening to her and hearing her explain so many of these things. And it is all part of the National Institute on Drug Abuse and the efforts being made to improve treating opioid addicts within the criminal justice system. And I want to thank you so much for joining me on DMV Spotlight on ESPN 630, the Sports Capital. You can check us out online at espn630dc.com. I'm Barbara Britt on ESPN 630, the Sports Capital.